Hi, I'm Bruce Malone. I'm an orthopedic surgeon here in Austin, and I'm also president of the Texas Medical Association. My regular job is an orthopedic surgeon, and basically I spend my day restoring function and decreasing pain. And I'd much rather be doing that than standing here in front of you talking about Medicare healthcare policy. For a physician today has to feel a little like the movie Groundhog Day. The same thing keeps happening over and over. Every year, thanks to a really bad formula that's in federal law, Washington threatens to cut physicians' payments for taking care of patients on Medicare. Every year, we urge, entreat, sometimes even beg Congress to fix the formula. Every year, Congress steps in at the last minute to avert the cuts and puts off fixing the formula for another year. This has been going on for a decade. And sometimes not paying the doctors for months at a time while they legislate. Here we are in October 2011. The formula is now calling for a 29.5% cut in Medicare payments to doctors at the start of the next year. And I'm here, just like physician leaders across the country, urging, entreating, not quite yet begging Congress to fix the formula. In Groundhog Day, however, the Bill Murray character wakes up to exactly the same day every time his alarm clock rings. That's not quite what's happening here. Every year, because Congress keeps denying the problem and delaying the fix, the problem gets worse for taxpayers, physicians, and our patients. In 2009, the cost to correct the formula was $249 billion. This year, the Medicare payoff amount has ballooned to $350 billion. The feds have been charging the problem to their credit card and paying the minimum amount every year for almost 10 years. This year, the potential cut in payments is almost 30%. Last year, it was 25%. In 2009, it was 21.5%. The worst news is that the new TMA survey finds that the number of Texas physicians who may be forced to leave Medicare if Congress doesn't fix this program is staggering. It's tragic. Medicare simply cannot work without physicians to care for the millions of patients on Medicare in Texas. And Congress can't wait any longer. Seniors and also current military families and Texans with disability are at serious risk of losing their doctor. Our survey indicates that half of all Texas physicians are considering opting out of Medicare program altogether if the plan cuts go through. We knew physicians would consider leaving the program, but we didn't think the number would be that high. Even when we asked them to consider a possible compromise cut of 10%, physician responses were the same. Half are going to leave the program. They would be forced. And we got more than just numbers when we sent out our survey. We got plenty of tragic but sincere comments as well. For example, Dr. Albert Shaw, an anesthesiologist from Fort Worth, told us he's done with Medicare. And his quote is, "It breaks my heart and haunts my soul. However, I have no choice if I'm to stay in business to care for any patients." So like Dr. Shaw, Texas physicians all across the state really want to keep our elderly patients. We love our Medicare patients. I've been replacing seniors' hips and knees for 37 years. Every day, I see the pain relief and the better quality of life that produces for my patients. I don't want them to have a crisis of access during the biggest growth in the Medicare population, the baby boomers, that's coming up. But I might have no choice but to retire early. More than half my practice consists of Medicare patients. Last year, my medical group laid off staff to help ends meet. And when I pointed out, sometimes they can't make up their minds, so they just don't pay Medicare claims for a month or so at a time. And we've got 680,000 doctors out in the country wondering what they're going to do for cash flow. So, you know, unfortunately, we also have to keep offices open and businesses functioning. This is not just a problem for tomorrow. Our survey found that 3% of Texas physicians already have opted out of Medicare. Another 8% already accept no new Medicare patients. And another 12% already further limit how many Medicare patients that they see. Now, what I'd like to do right now is introduce Dr. Greg Sheff from the Austin Regional Clinic. Dr. Sheff is one of the administrator and practicing physicians at Austin Regional Clinic, and as you know, it's one of our larger primary care clinics in town. How many doctors, Dr. Sheff? 300. Shows how out of date I am with the number. So it's a huge facility and a huge complex organization, but provides, it's the backbone of primary care in Austin. So Dr. Sheff, come up here and tell us what you're concerned about.
Thank you, Dr. Malone. I'm Greg Sheff. I'm a family physician with Austin Regional Clinic here in Austin, and I'm also a medical director for our group, and I'm very highly involved with our Medicare strategy. And so I want to speak to you not just from the perspective of a family physician, where certainly a lot of our mission is to take care of seniors, but also from the perspective of an administrator in a group. Just to give you a little sense of who we are and how that plays in, we have almost 300 physicians, and we do somewhere between 50 and 20% of the care here in Austin. We're a multi-specialty group with a big emphasis on primary care. We have made a very conscious and committed effort to keep our Medicare, the percentage of patients in our practice who have Medicare, reflecting the percentage of patients with Medicare in the Austin market. We see that as something we need to do consciously, because it's not something that in and of itself makes business sense. Even without any changes or cuts in Medicare funding, we currently spend about 120% for every 100% we receive in Medicare reimbursement. So we are essentially losing money on all Medicare patients. But again, we see this as a critical mission as a big delivery group here in Austin. However, if we take that and add to it another 30% of cuts, it just becomes unsustainable for us. And then we're in a position where we feel we have an ethical obligation to take care of our patients, but we also have a fiscal responsibility to run a business and pay our employees. To put all of this in perspective, if Austin Regional Clinic takes no new Medicare patients over the next 5 years, just because of the aging of the population, the size of our Medicare population will double. So what happens in Medicare is critically important to us. It's a population that we feel a professional obligation to serve, but we really feel like this is reaching a crisis point where we're not going to be fiscally able to serve that population as it becomes a more prominent part of our community over the next several years, unless the federal government really takes responsibility for fixing this funding formula so we can make some rational decisions going forward in order to make our group as accessible as we can to Medicare. The other point that I'd like to make, this is somewhat tangential to the direct SGR issue, but the other big option as we all look at the crisis in funding for healthcare in general is to try to give more efficient and higher quality care. And I think that in tandem with Congress considering getting rid of the SGR, it is also actively looking at new programs to try to encourage and incentivize providers to give more comprehensive and proactive care to all patients. And this is certainly something at Austin Regional Clinic that we're actively looking at doing to try to really continue to make healthcare something that's accessible to everyone in our community. Thank you.
Thanks, Greg. You know, all of us realize that the current economic situation with the cost is unsustainable. We know we have to make changes. And Dr. Sheff was just pointing out what some of those changes should be. We're going to get out of this the same way we've gotten advances in every other generation, and that is by innovation and scientific discovery, more efficiency, being able to do a better job with less. But right now, we simply can't do it by simply cutting the payments for one section of that part of the market. The second person I'd like to introduce is Barbara Carlton, and Barbara has been in Austin since the 50s, but she's going to tell you her perspective on what it's like to be a patient who tries to find new doctors and new people to care for her under the Medicare system. Barbara?
Good morning. I am Barbara Carlton, and I have been a resident of Austin for back in the 50s. I moved here with my family, and I have been on Medicare for several years now and have had the same doctors even before I went on Medicare. And luckily, they did extend my plan by accepting Medicare. And so I'm hoping that that none of my doctors will opt out, because it will be very hard to find a new doctor that will be accepting new patients. And I am under the care of at least 5 doctors right now, and will be going in for my annual physical soon, and I'm just hoping that I will be able to keep my Medicare as my primary. Thank you.
Thanks, Barbara. As a physician, I sometimes have my colleagues whose mothers and fathers move here. You know, the situation is I'm retiring, I want to be closer to my grandchildren, or I want to be closer to my family. And these are folks who've been in responsible positions in other cities and other parts of the country. And it's surprising how difficult it is sometimes when they're moving from a situation in a town where they've been for years and had their own doctors to come and try to start that over again and find new doctors, especially when their coverage is through Medicare. The only way to stop this Medicare meltdown from getting worse is for Congress to fix the defective formula used to pay physicians. For the past 10 years, Congress has delayed fixing the problem. Now, due to their inaction, the long-term viability of Medicare is threatened. Congress clearly values the care that hospitals, skilled nursing homes, home health agencies, and inpatient rehabilitation facilities provide Medicare patients, because the government has updated their pay every year for the past 10 years. To Medicare, their doctors' care is equally important, maybe even more so. So TMA believes at a minimum Washington should fix the broken physician payment system before updating the payment to the other healthcare providers. I want to call attention to this chart over here. This chart starts in 2001, and it shows the average small updates. I mean, these aren't extravagant updates that have occurred for the other facilities, but all of these are those agencies and hospitals we've talked about. The top green line is the hospital inpatient and outpatient updates. They've all been positive, small but positive. The red line is the physician payment update. You can see it went down for about 4 years, stayed level, went up about 2 or 3% over a period of another 4 years, and here's what happens January 1st. Now, if you were a corporate executive and they presented this chart to you at a business meeting, you would say, sell this company. And I don't think any of us would doubt that. Now, this is not a company. This is a group of doctors trying to take care of the population. So it's clearly unsustainable. The Medicare patients should feel anything but secure about the future of their health care. Physicians are the foundation of that Medicare program, and without a robust network of physicians to care for the millions of Medicare patients in the state of Texas, the program will not work. And this is also nationwide. This is not just a Texas problem. So I wish I could be a little more upbeat about this situation, but what we're concerned about is that there's all this conflict going on in Washington now with the alleged super committee to deal with the budget cuts of $1.2 trillion that have to happen. And we're afraid that there's going to be inattention to this problem that's approaching, and the last thing we want to do is to have it remain unfixed or no attention paid to it. So thank you all for being here, and I'd be happy to answer any questions that anybody in the audience has for me about the technical details. I did bring one additional item. The Texas Tribune produced a small article in the last week that best explains this mind-numbing complex SGR formula and what's gone on. I mean, it's really hard, it's impossible to explain in a public setting, but in about 5 paragraphs, it's really well outlined. And I brought a few extra copies of that. It just actually came out. So, thanks again. Yes, ma'am.
Dr. Malone, how many doctors responded to the survey?
I think we had, Pam, we had about, was it 16 or 1,700? We have 45,000 members. And you know, when you have a survey, you know, 2% is a good response, but I think we had about 16 or 1,700. Yeah.
It's on the, almost how many? It's on, I think it's 1,800, but it's right here in the survey itself.
It's on the survey itself.
And also on the press release.
We think that the numbers make it relevant statistically.
You don't think that ones who are planning to drop out might have been more likely to respond?
I don't think so. In fact, I think when you do these responses, a lot of times we're doing them online, we tend to get a representative of the younger physicians too.
And what is the difference in payment between what commercial insurance pays and what Medicare now pays doctors?
Well, that's variable depending on the contract. As you've probably known, but because of your question, a lot of the commercial insurers tie their payment rates to Medicare, but it's a percentage. Some of them are as low as Medicare rates for what we call evaluation and management, the office visits. Most of them are above Medicare, anywhere from 10 to 15%, and some of the rates can be as high as 20% higher for surgical procedures and things that are more technological. And then, of course, our workman's compensation system here in the state is even higher than that. So most of the time, I can say that it's probably about a 15 to 20% differential.
Okay, on average, you would say?
On average.
And is your practice planning to limit or stop taking Medicare patients?
We're not planning, and let me tell you why. I work with a group of 6 orthopedic surgeons, and we cover emergency rooms. So it's almost impossible for us to drop out of any system. I mean, for instance, I accept Medicaid patients because I take emergency call. But I will tell you that, just like Dr. Sheff pointed out, if you look at the numbers, the compensation for me to take care of a patient on Medicaid in the state of Texas is below my fixed cost for doing that. So every patient I take care of, the clinic loses money. But I do it as I think, a public obligation, and it's certainly a public obligation if you're on an emergency room staff.
And you get less from Medicaid than from Medicare.
Oh, it's outrageously less. The Medicaid crisis in Texas is real, but we're not even approaching that. It's literally about 60% of Medicare payment is Medicaid.
And you said that to fix the SGR would have cost 200 and something billion. What year was that? 249 billion.
That was about, I'm sorry, that was a couple of years ago. I mean, it started out at about a $35 billion problem a decade ago. You know, it could have been solved for a lot less, but it's grown. It's like as I pointed out, it's like your credit card debt if you don't pay anything but the minimum payment, and that's been going on for a decade.
Okay. And then, Dr. Sheff, I had a couple of questions for you.
Sure.
You had mentioned that your concerns about how many patients at Austin Regional are on Medicare and how that in 5 years, I think you said, if nothing were done, it would, did you say double?
So just because of the aging of the population,
Right.
if we take no new Medicare patients other than patients that age in, but they're already existing patients of ARC.
Right, and didn't drop them once they become 65.
Right, which is certainly what we do. Then our Medicare population will double.
In 5 years?
In 5 years. So, I mean, this is a very, very, very real issue for us. I mean, I think maybe the most telling thing is when I said in the beginning that one of my roles is over Medicare strategy. The fact that we have a Medicare strategy says a lot.
Mm-hmm. And so and how many total patients does Austin Regional have in Austin area?
It's a tricky calculation. We look at unique individuals we've seen over the last 2-year period, and the number is in the range of 350,000.
So is your practice, or is Austin Regional planning to limit Medicare patients at this time?
We certainly have no plans to limit our patients that are aging in. We are currently not accepting new non-ARC patients with Medicare. So if you move to town or your doctor retires and you have Blue Cross and called ARC, you could be seen, but not with Medicare. And that's not, I mean, we're not happy about that. In fact, that's a recent decision that we were forced into because of growth in our Medicare population. It just becomes not fiscally viable for us.
So when did you make that decision not to take new Medicare patients?
Last year.
Last year in 2010?
Yeah.
And
but again, just to emphasize, our existing patients that become Medicare, we certainly don't turn away.
And does that include Tricare in the 2010 decision as well?
I'm honestly not sure. I'd have to get back to you. And the other thing to let you know is that, you know, I mean, we certainly think this is something that can be fixed by the federal government, but we're also, as I mentioned, we're trying to fix this internally. It's just with these kind of numbers, it's a real uphill battle because we really do feel a professional responsibility to, you know, to care for the community.
So you all feel for every $100 of care you provide, you lose 20% of that? Or?
I mean, to some extent, what this is, you know, saying is that it costs about this is kind of what this line is the physician practice cost, and it's about 20% over where the SGR line is, and this is with them, kind of pulling back on the SGR every year. But they're still, even when they pull back, it doesn't get up to where it really. So Medicare over time has become more and more untenable to take a larger part of your practice.
This line, I mean, the space between the black line, which is the physician price cost medical economic index. This is what the increase in my practice overhead has been over that period of time, and this is what my Medicare payments have been. So you see, it started out as a few percentage points, and now it's quite significant. And it's just the reality that you can't sustain something that has no growth in fees or payments if your overhead is growing. So that's the issue we have.
Did you have a question?
Yes. The purpose of you having this press conference today is to bring this to everyone's attention. But what can we do as consumers to help rectify this problem? I mean, what can we do?
Sure. You want to take that? I mean, that's really.
Well, I will tell you that we've been appealing to Congress for a decade, so you know that has not worked. In fact, this was part of the negotiations for the Affordable Care Act, solving this problem, and it wasn't done. So the answer is, I think the only group that Congress is going to listen to is everybody in the audience. I mean, they're much more interested in what you think about this than what I think about it. Although, I will tell you, I had a meeting with Don Berwick, who's head of CMS or Medicare, about 2 weeks ago in Dallas, and he's made a public statement that this can't happen. This will be a disaster for access. But he runs the CMS. Obviously, they're the ones who pay the claims, but this is, as he pointed out to me, a statutory right of Congress to deal with. He can't unilaterally fix this. I want to thank you all for coming, and I want to especially thank the Renaissance for letting us use this nice facility and have this press conference in an area where obviously Medicare is very important This is a very large facility, provides a wonderful environment for people who need a little extra help in either apartment living or assisted living. And I very much appreciate their hospitality and graciousness in having us here. And unless there are more questions, we'll just let you all go on about your day. So thanks for coming.